Welcome to this morning's session. Participate using your skills, knowledge and experience to improve your child's health or your own. I'm Paula Reid and I'm the Executive Officer of Cystic Fibrosis Tasmania, and it's my pleasure to introduce the guest speaker for today. Now, did everybody get 2 stickers on their way in? If you didn't, rush to the back of the room now, we won't watch. You just got to get doesn't matter if you get hearts or stars. And there's going to be a little bit of audience participation. Yay! Don't you love that on a Sunday morning? So the thing is, if you've got stars, you're going to be doing star jumps later. If you've got hearts, you've got to kiss the person next to you. So if you want to swap stars and hearts, do it now. So we all love a bit of audience participation, so look forward to that. It's my pleasure to introduce Susan Biggar this morning. Susan has served for nearly a decade as a consumer representative on a range of health-related committees, and she was the inaugural chair of the Royal Children's Hospital Family Advisory Council, where she has sat on the Clinical Quality and Safety Committee since 2009. Now a Senior Manager at Health Issues Centre, she is also a Director of the Australian Institute for Patient and Family-Centred Care. Susan is a writer by background, and she's written a range of publications, including writing for The Age, Good Weekend and The Big Issue. Her first book, The Upside of Down, was released in September 2014 by Transit Lounge. Originally from San Francisco, she's lived in 6 countries over the past 25 years. She loves outstanding coffee, the beach, her family and roller skating, but that's not the correct order, just a random list of things. She has 3 sons, 2 of whom are living with cystic fibrosis. Susan is quite happy to take questions as you go this morning, or you can keep them to the end if you'd like to, but feel free to interact as you go along and ask all those burning questions. So could you please give a warm welcome to Susan Biggar.
Thanks, Paula. Well, thank you all for coming first thing on a Sunday morning. I do appreciate no star jumps, I promise, and no kissing unless you choose to do it yourself. So can I just ask first for, just so I know who's there, because I definitely want to be hearing from you and interacting with you. Can you tell me, hands up, people in the room who have a child with cystic fibrosis? Okay, and hands up if your child is over the age of 12. Okay, hands up under the age of 12. Okay, thanks. And people who work for cystic fibrosis associations? Okay, and either CF adults or spouse or sibling? Okay, great, thank you very much. So I appreciate that. So I'm gonna start off with nothing, it looks like. With this, because even though I've spent 13 years in Australia and I now have an Australian passport, when I tell people I'm from Camberwell, they laugh at me. So I am originally actually from San Francisco, and this is really where my story started. And what happened then was that 25 years ago, I met and I married not a sheep, actually, though just as bad for most Australians probably. I married a New Zealander, and that was sort of what ended up causing a lot of trauma in our life, probably, no. But then we moved around quite a lot, and eventually we ended up having 3 children. 2 of them were born in New Zealand and 1 in France. And that is, I think, where my story intersects with many of your stories in this room, and that is because we were told along the way, Daryl, my sheep husband, and I, that 2 of our 3 sons, Aiden, the oldest, and Oliver, have cystic fibrosis. And so one of the things that news obviously came with many, many things, which many of you will be very familiar with, and which we aren't really going to talk about today, about the challenge of that adjustment and what that meant. But it also came with something that surprised me a lot, something I didn't expect, and that was this. That was the fact that I would suddenly have to have a lot of relationships with health professionals, and that those relationships would potentially prove to be complicated and challenging, and probably would challenge me in ways that I really didn't expect, and that might be the case for you as well. And that's not because these people aren't on the same side as me. That's something I realized really quickly, that not only are they very, very important for people who have family members with cystic fibrosis, but that for the most part, health professionals have exactly the same goals that we do, and they want what we want. But they are often very busy and maybe don't even have time or ability to communicate what we feel like we need. And so it makes that relationship potentially complicated because we need them very much. But one of the things I learned early on in my family's journey was that, and I think it's a very important thing, and that was that they need us as well. That they want, because their goal is to provide the best possible care to get the best possible outcomes, they cannot possibly do that without us. So we do need each other in this relationship. It is definitely a two-sided relationship. But I think trying to figure out how that works is one of the more challenging things. So before we start to delve into this, I just want to talk a little bit about what I hope to do in this session. And that is, I want to talk for, oh, why is that going away? They do not like me. Well, I want to first talk about showing that participation matters for us, sharing some tools that might help us, talking about the issues that matter to you, and hopefully trying to develop a plan or start to think about what it might look like to develop a plan for solving some of those. So first, can I ask, when you came to this session on participation, maybe it was because you didn't want to go to the transplant session, but was there anything particular anybody have that they say, oh, I really hoped we'd talk about this, that's not on that board, is it? No? Okay. Might come to you as you go along and tell me, because we definitely, it's going to be, I want to be hearing from you as well. But I want to start off with a story, because I am originally a writer, so I do probably think and talk in stories a bit about our own family's participation, because I think we all have a participation story. So when Aiden, my eldest, was 2 years old, we moved to France. And we had 5 years living in France, and there was a lot that we loved about our experience in France, and then there were some things that we found extremely challenging. And I think when I realized, because my second son, Oliver, was born there, and so suddenly I found myself with 2 young children with a serious chronic illness, and obviously I hadn't planned very well. I didn't speak French at the time, and so that put some obstacles in our family's way. And that's a great motivator, actually, to learn to speak. But I found that there was information that I couldn't get. There were things about the way the system worked that I didn't have what I felt I needed, so that I ended up feeling that it was very hard to participate, very hard to be involved. And then at one stage, Oliver, who's the guy in the little stripy pajamas, he had a month in the hospital in Paris. And one of the things, I've mentioned this maybe in the past before, but one of the things that was hardest for our family was that there happened to be a rule that no siblings were allowed on the ward. And so that's a month with our 2 young children really not seeing each other. This is the 2 of them sitting outside the elevator, having sort of a very brief encounter in that month period. Now, no one made those rules to say, gee, let's make life hard for families. I'm sure of that. But they weren't necessarily thinking about the impact that a rule would have on a family. Now, that was not a cystic fibrosis-related rule. That was just a hospital-wide rule. So that is one of the things that I think when we think about participation, there are some areas of participation that involve specifically kind of CF-related policy. And then there's some that are just sort of hospital-wide. And it is important for us, and one of the things I want us to talk about today is, or to begin to think about is, when we come up with an issue that is a struggle for us, either personally or for the whole CF community or service, we need to think about whose issue is that. You know, this is a hospital-wide issue. Siblings aren't allowed on the ward, so that's where you have to move. Whereas some issues are just at your CF sort of unit level, and that's a different kind. So this was probably my first participation story, where I realized, okay, this isn't working for me. I'm not able to participate. There are things from my family that aren't working, and I'm not able to have an impact on them. I'm not able to say, this doesn't work. What I'd like you to do right now is just take a minute to think for yourself. You can talk to the person next to you. Maybe even better, take 30 seconds at least to think for yourself, if you can, of one thing in your experience that's been where you thought, oh yeah, I was really able to participate in my child's care or in my care. I really felt like that was great. We were able to communicate about an issue, or we had something tricky that happened, and I felt like that was a positive thing. And I'd like probably also for you to think about one that didn't go so well. So take 30 seconds to think about something where you were able to participate, and one where you thought, oh, I didn't have a voice. I couldn't do what I wanted. We didn't get our way, or however you want to phrase it. Okay, now your issue might have been an individual issue. And I think this is a really important thing. We're going to be talking this morning about two different kinds of participation. I'm convinced that already you are doing number one, because effectively, even if you're doing it unconsciously, 95%, 99% of our lives is spent at home. So we do 99% of the care, and as our kids get older, they do more and more of it. But so you are participating already, but the individual participation might be about how am I able to get things that I need in my own interactions with my healthcare team. Whereas on a system-wide level, it might be things like, can we change the policy about siblings coming onto the ward? Or what about the cost of parking? Or what about cross-infection issues in my service? Those are the kind of things that might actually impact on lots of people within your community. So we're just going to try to sort of differentiate in our minds between those. So the first thing I want to talk about is why should I participate? Now, anybody who's ever had a conversation with me over the last decade has probably heard me talk about this article, and I apologize if you think, oh, here she goes again. But I actually think now, even, 11 years later, it's still relevant. And if you haven't read it, I encourage you to read it. The New Yorker magazine is, a literary magazine. It's not a medical journal at all. Very, very accessible and very easily found online. And Atul Gawande wrote this article. He was interested in quality of care. When we talk about quality of care, it's quality of health care in general. And he was looking at quality of health care, and he chose the area of cystic fibrosis largely because there had been data collected in cystic fibrosis since the 1950s. And there were very few conditions where they had that kind of data across lots of services. And so it was really, really interesting case study. So one of the most important things that he found, he wasn't doing sort of any kind of a high-tech qualitative study. He was just looking at what some of the differences were between centers. And one of the most important things he looked at is, well, how long are people living at different centers, right? It's one thing we always are thinking about. And you have to understand that even then, in 2004, America had probably at that point 115, say, CF centers across America. And they had a very, very strict set of requirements for what you had to do to be considered a center. So it wasn't like you could do whatever you wanted. You had certain things you had to do around when you prescribe antibiotics and how many nurses you have and physios and so on. Even with that, what he found, which was very surprising, was that if you were, in 2003, you can read that bit. Basically, if you were at a median center, so at a middle-range center, right, your life expectancy at that point, on average, was 33 years. If you were at one of the top 5 performing centers, you were living almost 48, so almost 15 years longer. That is enormous. And obviously, for people who live with a child with cystic fibrosis, I don't have to tell you how enormous that is, right? So for me and my husband, Daryl, when we read this, we thought, really? Really? This really matters. This really, really matters. And that's my first point, I guess, when thinking about why should I participate? Because the quality of healthcare we receive really, really matters in CF. And that is a positive thing, because there's a lot about CF that we can't do anything about. Our kids have it. That's it. We've got those genes. There's some things we cannot change. We can have an impact on this, right? And this is what we have to start thinking about. And so this is what I think one of the reasons we have to get involved is because the quality of healthcare we receive really matters, really does matter. And the second point is because participating can improve our health and our healthcare. Now, this is a guy that I met years ago, a pediatrician in California. And as you read, he said that over his lifetime, and he'd probably worked 40 years in CF at that point, he said we'd seen lots of changes. Most of them came through by patients and family members saying, we need something to happen here. This isn't good enough. We need this. We need that. Probably, hopefully, they did it in the nicest possible way, which I will say over and over again, is that we have to say what we have to say very clearly, very strongly, and in the nicest possible way, because that's the only way we will achieve things. But I think this is that's my second real point, that I actually could go on about lots of reasons why we might participate, but just the two for today is because quality of care really matters in CF, and because participating can have an impact. It can actually make a difference in the care that's provided. And I want to talk about why that is. So Atuguande, while he looked sort of briefly at these things and put out that shocking statistic about the 14-year difference in life expectancy, then after that, a number of other people went on to look and say, well, is this really true? What are these differences? Because they're always going to have some kind of a bell curve, but nobody expected it to be such a big one. You would have thought it might be that, the top place you live 2 years longer or something. Well, even just recently, at the end of 2014, this paper came out, and I would encourage you to read it, even if it's a little bit more hard-going than the other one. It's in what's called the BMJ. I think it used to be called the British Medical Journal. I think now it's just called the BMJ. But so what they did was this group said, well, we already know some of the things that make one CF center sort of better than another. There were some things that had come out about things like the better CF centers, meaning the ones with the better outcomes, do things like they take more sputum samples and they have more appointments, and they, there were some really sort of clear things you could tick off. But this group said it would be really interesting to know what's behind those things, meaning not just how many CT scans do they do and so on, because we knew a lot of that, but there was still a range within that of how well people did. So what they wanted to know was the top centers, the really top centers, what exactly are they doing different from the other ones? Because they are still getting some big differences in outcome. And so, excuse me, what they did was they went and visited 20 centers, a bit like our peer review program here, and they spent time at 20 different hospitals. And 10 of them were the top. They had 5 that were the top in lung function and 5 that were the top in BMI, so in weight, nutrition. And they went and they said, okay, what are those top places doing that's different from everybody else? And these were the things that they found. These are kind of generic, and you'll have to read the article a bit, but they were 5 really important categories. Now, just to give you an idea, by systems, it was things like, what was really important for systems was the leadership and how the team worked together, and whether or not whether they were well coordinated. I mean, it makes sense, right, if they're a good team, so that the clinicians worked well together. Under attitudes, now this was very, very important, I think, for me, was that attitudes was about the fact that the top centers, do I have this on the slide? Let me just see. No, the top centers were both the staff and the families had very high expectations about outcomes and about slippages. So they didn't accept any kind of change. So they had very high expectations about how well people were going to do, and that the attitude actually really mattered. Practices were things like, I'm trying to remember, pre-clinic meeting, where they had pre-clinic meetings. So there were things like that were really important, that made a center work a little bit better. I'll come back to patient-family engagement, and projects was about whether they looked at what they'd done and they evaluated, and they said what's working well, what's not working well. They were very able to look at themselves and constantly innovate, right? So this might look a little bit boring to you, but this is actually really important for us, because you have to know, and I hope that in some room somewhere else, this is exactly the kind of thing that the CF center directors are saying to themselves, what are the best places doing? Not because we want to say, oh, and you're the worst, because that is not at all what it's about, because we all want the same thing. And that's something I'm going to say over and over. We all want the same thing. We all want people with cystic fibrosis to live the best lives and the longest lives they can. And the health professionals want the same thing. And it's good for them, not just because they're good people, but because it shows they're doing their job well, right? So patient and family engagement and empowerment. So this was important, and this is obviously important for us, because most of us are patients and families in this room. These were the things that the high-performing centers were doing, that patients or families were provided with data on their clinical outcomes. So how many people here, I hope to see a lot of hands, but how many people here would go to, and can I just say, we're not saying any names about what centers we're from in this session, but how many people would go to their clinic and get a graph which shows how FEV is tracking over the last few years? Okay, some. How many people would get an FEV for the day, a chart, and that they would take with them, take the piece of paper with them, okay? And what about BMI? Would you get the same with BMI? Your weight? Yep. And show how you're tracking. Great. So you would be able to say, I know my child's FEV1 is this, and I know my child's, say, in the 75th percentile for weight and height. Great. So those are the kind of things, and maybe even with more detail, that these centers were doing. They were also finding that patients and families were, this is what I said before, I'll come back to, they were educated on high outcome expectations and the need for early aggressive intervention. You see, the thing is, in cystic fibrosis, we can't wait for the doctor to call us up and say, how are you going there? Is he doing well? We have to be the ones who get up and say, hey, he's not doing very well. I'm worried about this. Even though there will be times when those will be false alarms and we'll feel really stupid. But let me tell you, it's a lot better to have a false alarm than to not call for 7 weeks and come into clinic and then say, why didn't you call us? He's clearly not well, or she's clearly not doing very well. The onus is on us. And they don't want to put it on us because they feel bad, but it has to be on us. Not because they can't do a good job, but they have a lot of patients and they can't be calling us up to say, how are things going? So the centers that did well were the patients and families understood how important their role was to initiate something, to make the phone call. And interestingly, one of the things that the best performing centers used was they used the telephone. Was that families knew they could contact staff when they had concerns by the old-fashioned telephone, and they could get them on the phone. And they could get a response. Or by email, they could say, I think they need to start on antibiotics. They could email them and say, great, go ahead and do that. You've got the script at home. It was that really interactive thing. It wasn't wait till you come in 3 weeks for clinic. They also found that the best performing centers, for example, were very quick to intervene. So the average number of days of waiting before starting oral antibiotics at the best centers was, I think, 3.7. At the lower performing centers, it was closer to 9 days. That might not look like much, but it can be a big difference. Because the best centers weren't performing rescues. That's a really important thing. They weren't waiting until someone was really sick to put them in the hospital. Because we know, and I think it was Barry maybe who said this yesterday, we know that if you get an exacerbation, 1 in 4 of your exacerbations, your lung function is not going to return to what it was before. So we don't want to have exacerbations. We don't want our kids to have exacerbations, and we want to avoid that. Does that make sense? I've really been talking a lot. Do you have a question? Okay, don't be afraid to stop it. I hope this is, okay. So that was my why should we participate. I hope you're still thinking, yeah, okay, I think I do. I think I get why this is important because I feel, you'd never guess, but I feel quite passionate about this, that this is really important for us. So how should I do it? How should we participate? Now I had a list when I started of about 15 things. And Daryl's like, oh, honey, come on, be realistic here. I said, okay, fine, 4. And I think they may look very simple, but I think they're really important. So believe in yourself. Here's the thing. This is my experience, is that it's about having a strong sense of who we are in this relationship. We are the homeowner. So about 4 years ago, about 5 or 6 years ago, we bought a really old, lovely but falling down house. And when we went to get our falling down house renovated, we got an architect. And he was critical, and he was lovely. And we really needed Michael, and we needed his expertise. And there were some things where we needed him to really say, no, from a civil engineering point of view, you need a pillar there or whatever. But you know what? It was our house. And we were going to pay the bills, and we were going to live it, and we still do. And so the decisions we made, the mistakes we made, the things that we felt strongly about, we needed to be able to say, no, it's still our house. I know you think we should do that, and I know as an architect you think that would look really cool, but it's our house, we're going to live in it, and these are the decisions that we need to make. That is who we are in this health scene. It may sound obvious, but we are the homeowners. We're paying the bills, we're living in the place for us or for our kids for forever. And so we need to feel that we have a very strong sense of the important role that we play in this. We are absolutely fundamental. It would be silly to try to go about this without an architect. So we need the health professionals, we need their expertise, but at the end of the day, we are the decision makers. I think we need to be the primary decision makers, and as our kids get older, that they become the primary decision makers in their health care. And that takes an enormous amount of confidence in some ways to feel that, because we can feel very intimidated by the knowledge. Don't underestimate the knowledge that you have of living with your condition or of living with your child and understanding what works and what doesn't for them. And the best doctors, in my opinion, best doctors, the best physios, the best dietitians, really value that and really see that. Jen.
I was just going to say a really nice quote which reminded me of this. There was an adult living in CF, and he said that I always remembered during my healthcare that you might be an expert in CF, but I'm an expert in CF in me.
Absolutely.
That's a really nice quote,
Yeah,
because
absolutely.
you're not the expert in your own body or
Yep.
your child's body, you're watching it day in, day out.
Absolutely. That's exactly right. And if there's one thing we find, I've seen this already, you can talk to, it's great to talk to other families, but you are not going to ever meet somebody who has had the exact same experience as you, or has grown the same bugs, or has responded in the same ways. In the back, a question really loud, or a comment.
My daughter, she's 5, and she said to me, "Where are you going again this weekend?" I said, "I'm going to a CF conference." And she said, "Why are you going to a CF conference? I love CF. I can tell you everything."
Fantastic. And that you hope that she'll continue to believe in that. And she won't lose her sense of, still needing that relationship. We need the health professionals, but to believe in that you have knowledge that's really important. So that brings me to my next point, which is learn. And it's not about learning, what do I need to know? It's not about saying, oh God, I don't know what the health professionals know. What time is it? It's not that I don't know what the health professionals know, because I don't need to know what they know, but I need to know what I need to know to do my job better. So you're doing the right thing. This one I don't have to tell you because you're here, right? And that's what we're doing here is we're trying to learn. We're trying to learn the things that we need to know to do our job better. But it may be about asking, it's not necessarily, and my second point about how am I most likely to do that is that don't put pressure on yourself and say, oh my God, I really should be staying up at night after work and after getting the kids to bed and reading lots of articles in the New England Journal of Medicine. That's just not going to happen for a lot of people. So you need to think, how am I going to learn? Do I need to get involved with a parent group? Do I need to really encourage my CF organization to provide some education nights? What kind of, how am I going to learn? How am I going to push myself? Because I've got a lot of other things in my life, but I have to learn. There's certain things I need to know. The thing about let knowledge be a friend, not a foe, is particularly directed, I think, at us mums here in the room. And that is that, for example, there was a study that I remember reading years ago which found that there was a link between the mothers, between maternal CF-specific dietary knowledge. So the amount that I knew about what the good CF diet was linked to good weight for my child, which we know is linked to good lungs and which is linked to good outcomes. So I could look at that and I could say, which I think some mums do, some of us mums do, oh my God, my child is thin because it's my fault, because I don't know enough about the CF diet. But if you ask me, that is not the response we should have. We should look at that and say, fantastic, that means that the more I don't need to have a degree, I don't need a college degree or a PhD, I actually just need to really know my stuff about the CF diet. And if I do that, I'm gonna give my child the best chance of having a better weight. And so I can look at it as a positive thing and not feel guilty about it. So we need to take the knowledge and not slap ourselves around the head about it and say, oh, my child's not doing well because I'm not doing a good job. No, or because I don't know enough about the CF diet. Instead say, look, this is what I need to know. I think guilt doesn't help us, but knowledge does. And so we have to always be really pursuing knowledge. Ask, ask, ask. This is obvious, and hopefully you're already doing it, but that is to constantly be asking for what you need. Asking questions, and if you can't do it in clinic, figure out when you can do it. If you need something from your health professional, if things aren't working for you, you need to ask. So this sputum jar is to remind me that one of the things we found really frustrating in clinic was we'd come in and we would sit through a whole clinic and we'd make a plan, and often, with both kids there, and they'd do sputums when we were at the hospital, and then we would go away, and a week later they'd call me up and they'd say, oh, actually, they've grown this or this, so we're not going to do what we talked about last week. And often it would be a message on the machine. So we'd had this long conversation about something that now wasn't going to happen and something else was going to happen. And I thought, this is not working for me. So is there another way around this? And eventually, it turned out that it was not a big deal to get a whole bunch of path slips, so that I could put in jars, so that I could get a sputum sample, if we have an appointment, like we have an appointment next Friday. So I'm going to send my husband a message tonight to remind him to try and get Oliver to get a sputum tomorrow, drop it into the hospital, so that when we come into clinic on Friday, we can say it's on the computer. This is what he's grown. So what do we need to do? Now, some people will say, And the hospital sometimes does this to me. Oh, but not every parent can do that. You live close enough to the hospital. And I would say, well, that's true. But there are local clinics. And so what are some options for people to be able to do that locally? Because we know the more sputums we take and the more we take them at good times, meaning, like, for instance, not everybody can cough something up when they're standing there with the CF nurse holding the jar out or the physio. But you might be able to do it first thing in the morning when you wake up. And so you pop it in the fridge, lovely, I know, but you pop it in your fridge and you bring it off. And that one, for me, only happened because I asked, probably in a teary moment or something, but I did ask. And this was another one, was that I happened to be at my GP's a number of years ago. We don't go that often, but we have a connection with her. And she had this letter on her desk. And it was a letter from my CF physician to her, telling her about the appointment. It was an appointment summary letter, something I'd never heard of at the time. It listed all the meds he was on and what he was doing and so on. So I said to her, oh, that is fantastic. Could I have a copy of that letter? And she said, yeah, but why don't you just ask your clinician. I'm sure he'll CC you on it. He'll give you a copy. Of course. He said, fine. So I get these letters now. I've been getting them for years and years. Hands up who gets the appointment summary letter. Okay. Hands up who might find 2 months after an appointment that the night before you're going in, it was helpful to remind yourself of what you did the last time. Okay, there's one hand up. Some hands up. So, because the way I use it is that I just will go, oh yeah, we said we were going to do this. So that's something I need to ask him about today when I go in. Maybe particularly for me, I have 2 kids, and that was really hard to remember what was going on with which. But these are the kind of things. It actually wasn't any trouble for him to just copy me on it because he was already writing the letter. But I didn't know the letter existed. So we need to ask. We need to ask for what we need and constantly be thinking, is this working for me? And the final point on how do we participate is to be vigilant. This is a doctor who I loved. I've heard her speak a number of times over the years, Brigitte Strandvik, and she's a Swedish pediatrician. I think she might be retired now. But one of the things she said to me years ago, which I have remembered very strongly, which is we should never tolerate deterioration simply because a person has CF. We should never tolerate deterioration only because they have CF. If your doctor says to you, well, what do you expect? They've got CF. I would be thinking about where else I could look for care personally, off the record, because there's always a reason. So if their lung function has dropped from 98 to 92, there's a reason. It's not just because they have CF. Yes, people decline over years, and they used to say it was, and they maybe now say 1% to 3% on average. But that's not just an inevitable decline. I mean, it's because of specific things that occur. So we need to say, is his lung function or her lung function dropping because of a particular bug, because of this, because of that? What is causing it? And that's about where we really have to be vigilant and say, well, I know that, they might say to you, well, 88% is actually pretty good. I'd say, well, it's not pretty good compared to the 94 he had last time. Okay, we only ever should compare ourselves to where we were last time, not to what somebody else is doing. And hopefully that's what your health professional is doing. I know it's hard for them, but if they say to me, but it's much better than a lot of people I see, I think that's not really relevant for me. Okay, and that's what we need to be saying to ourselves as well. In the nicest possible way, we need to be saying these things. Going back to that article, the top performing programs almost uniformly described having a low threshold for treating any decline from baseline. So they didn't allow for a deterioration. If they saw a deterioration, they responded. They did something about it. They said, this is not good enough. And it often was only a very small change. So they said, well, she has been 99, and now she's 96. Wonder what's going on. Well, 96, well, maybe, and that was often the difference, that they actually responded quickly. Not necessarily an overreaction, not necessarily a huge intervention, but they at least tried to figure out why it was going on. Okay, participating together. So we've talked a little bit about participating as an individual, and I hope and I'm sure that a lot of these things that that I've been talked about so far are already things you're doing. And if nothing else, it's really just to stir up that sense of, am I asking the questions I need to be asking? Do I feel empowered to do that? How do I do that? This is sort of the next step, and I think one of the things that I really realized when I came to Australia, and there was a lot that I loved about the care here, and it was such a relief, and people were speaking English, and that was wonderful. And there was a lot of things that were easier. But I realized pretty quickly that I couldn't make changes on my own. So that if I wanted to improve things for cystic fibrosis for my kids, I needed to get some other people on board to do that. And this is really what sort of participating together is. It's thinking about how do we think about system-wide issues. And these are the 4 things I would recommend. The first one is that we have to link up with other people. We cannot do it by ourselves. And if you don't know people from your cystic fibrosis center, meet them today if they're here. Really, because even if you come from different walks of life and different backgrounds and different priorities, the 2 of you together will have a much stronger voice than 1 of you. And you get 10 of you, and you got a full team. You say to your clinician, there's 10 of us families who are really interested in seeing this change happen, and they will have a meeting with you. If it's just you, they say, oh my God, it's you again, Susan. Sorry, you need to go away. So you don't want that. You don't want to be, and it's also hard. It's hard to be the person all the time raising things by yourself. You need some companions here along the journey, I think. Think broadly, that is very important. So this is where we have to drop our sort of the I'm a one-trick pony kind of thing. I'm only interested in this one issue, and nobody else really cares about it. That's not thinking broadly. To think broadly, we need to say to ourselves, okay, this is my concern, and then you say, is this a concern for other people? And then we have to ask people. We really have to ask people. Have to ask them all the time. And so we have a support group. There's some people here who come. We meet once a month, and we talk about things. And so I'm able to hear from people. What are they thinking about? And are there issues like my issues? And so if I go to bat on an issue, I want to make sure it's not just for me, because that's not thinking broadly. Then the third one is focus on what we know. Now this has been a learning curve for me. Oopsie, those are those. Okay, so focus on what we know. This is what we know. We know about our experience with the health system. That's what we can talk about. We know about how our experience made us feel or made our child or our spouse feel. We know what worked for us, and we know what didn't work for us. Now, the bit that I've had to learn is to focus on what we know and not on what we don't know when we're working with health professionals. We don't know how the staff feel about situations. Sounds obvious, but we don't know how the staff should do their jobs. And we probably don't know the definitive solution to improving care, though we definitely can have some ideas. Now, that might sound really self-evident, but I think that it is important that when we go into work with the health professional team, that we come at it with that kind of a humility to say, look, I don't know how you guys should best do your job, even though inside you're thinking, I have a couple ideas. But we keep our ideas to ourselves in that point, and we say, but these are the things. It's like in a counseling session, how you have to speak, you're there and you're saying, oh, my husband's driving me crazy. We actually have to say, the way I feel sometimes when he talks to me is, it's the same with this. We have to really try to focus on what are our concerns, and maybe what are the concerns of the 10 or 15 other families we're representing, but not focus on sort of how they should solve, not on they're not doing their job well, because they are trying as hard as they can. No one comes to the hospital to do a bad job. They're often, they don't have enough resources, they don't have all sorts of things. So it's about really thinking positively about thinking about change. And the final point I want to make is about picking your issues carefully. So this is my lovely dog, Jess, and she's very smart, and there's a lot of things that she gets right about. 5 o'clock, she knows it's time to get dinner, and she'll drive you crazy until she gets it. Things like that, really smart. But there's one thing where she absolutely loses her head, and she really is overly focused on an issue, and that is that she can spend literally hours staring through this hole that's this small, I don't know if you can see a little tiny hole, in our fence, waiting desperately for the next door neighbor cat to walk by. Thinking she will get that cat through that tiny crack in the fence, right? Well, now, Jess, we all know she will never get that cat, the stupid dog that she is. But she is so focused on it that she cannot see that she's not going to get the cat. And I think sometimes, and I've certainly had to learn in my life of working on these issues, that we have to really step back and not focus on issues we will never win. And one of the ways that we do that is, I think, by really getting together with a team of other people, of other parents and families, and saying, okay, here, what is this? Let's get some perspective. What do we really need to make our lives better? And I think it should be about our lives better for getting better outcomes or getting a better patient experience. There's nothing wrong with saying that your policy of not letting my sibling into the ward might not help Oliver or Aiden live longer, but it's going to help me today, and that is valid. So thinking about the things that really do matter in our patient experience and for outcomes. I really encourage you to think really strongly, to not fall into the Susan Biggar trap of doing things that aren't really winnable or maybe not worth it, or the Jessie trap, I should like to say. So now is your time to hopefully you still have your stickers. If people come in late, they don't have them, and get them off the chair. What I want you to do is Jen has kindly put up a number of bits of paper for me on the back wall. We only have sort of I want you to do this in under 5 minutes. To get up, go to the back with your 2 stickers. You need to pick, of those sheets up on the wall, what are the 2 things you really would love to see that maybe aren't happening in your center? What are the 2 things that really matter the most to you, okay? And put your stickers on those really quick, please. 2 stickers, 2 sheets. You have to kind of squish in there. That's the way, good job. Get up and just start applying them. You know what matters? Put them up there. 2. I know you probably want 10 stickers, but you only get 2. Okay, quick, once you put your stickers up, move back. All right, push your way to the front, guys. Push your way to the front. Get your stickers up. Yeah, you can do your star jumps now. That's right. Or your hearts. Give a kiss if you want to do your. Yeah. Until the end, okay. Is that right? So is mine slow? 12 minutes? 12. Okay, good. All right, just want to make sure it was on time. Jen, can you do me a favor and do the count up of what are the? Let's go with the top 2. So if you've got your stickers on there, come and sit down. Now, while Jen's counting, I want to tell you a quick story that I think is relevant for this. Well, first, how did you find that? Was it too hard to pick just 2? Or you knew right away? Too hard. Okay, and let me ask you this. Were there things that weren't on the wall that you immediately thought, well, where's this? Meaning, was there something else you really wanted to be on that wall? Any other issues that jumped out at you? No. So I'm going to tell you a story of an example of what change can happen. In our service, actually, because in the middle of the night, I was thinking about something that I didn't put up there, which was a big issue in our hospital, and that is the way that we put lines in used to be a really significant issue. And so for most of the kids, getting their line in was by far the toughest thing about it. And would you say that's changed, Lisa, at our hospital? It's still tough for you, okay. Well, so for what has happened, though, we've had a change in how that's done. And probably about 5 or 6 years ago, a couple of families were saying this isn't really working for us, because what would happen would be that you'd come into the hospital, and in the treatment room, they would make 4 attempts to get a line in. It was a PICC line. Were they PICC lines? Yeah, PICC line. And And for some kids, like one of mine, it just never really went down very well, and often didn't work. And if you've gone 4 times, I think you're less likely every time to get it because they're getting more traumatized and so on. Anyway, thankfully, there was an anesthetist who was particularly interested in this, and she met with families, ended up putting out a survey around the CF families to say, was this a big issue? Was it working? Was it not working? And over a period of time and a lot of momentum and her working very hard on it and input from families, the system changed. So now there's no more IVs put in or long lines put in without guided radiology, so without an ultrasound. We got a little machine and a very, very skilled anesthetic tech who puts them in always with guided radiology. Or else if we know in advance that you're a child who has significant issues getting their lines in, then they're not given a bed without being given a slot-in theater as well. So it's about sort of pre-thinking and not always ending up in a rescue situation where there's been a crisis. I mean, it is kind of a crisis to have 4 goes and have your child be a mess. And I speak from personal experience on that. It is really crappy. And so anyway, that was a really big thing for us. And I think to see the change, to see that the center could actually change, thank you, and could say, you know what, this isn't working for families, so what do we need to do to change that? It's a reminder that things can change. And we always have to say that to ourselves, that if I'm having a problem, possibly lots of other families are having a problem, what do we need to do to change this? Because if we're having a problem, then the team is also probably having a problem. They're probably not very happy either. Okay, here's my top 3. Great. The top one is hospital in the home is a good, effective, and available option for me when I need it. So is that first of all, is that a issue that you think is an individual issue or a system issue? What's that? Both. Both, yeah. Okay, so, and most system issues are also individual, but it doesn't necessarily work the same way. If it's just my child doesn't like, blah, that's individual. So that's clearly something that affects a lot of people, and that they really want hospital in the home to work because it improves your quality of life, right? And how many people, put up your hands if you feel like this is really working for you right now. Okay, put up your hands if you feel like this system could be a lot better. Okay, so then it's about saying, maybe finding some other families, right? And saying, are there other families who have the same struggle with hospital in the home? What are the really big issues? Because initially, I mean, we have to understand what the touch points are for the hospital too. If we go to them and say, we need more funding for this, well, it could be a very short conversation because they'll say, well, I don't have more funding. So let's say, well, let's think more creatively about this. What could we do? What is not working about hospital in the home? And it could be that they're not getting more funding because they're lining up like everybody at the trough, at the CEO's office, and saying, or the CFO saying, we need more money, and they're not giving it. So you might be able to go with a group of families and say, look, we know it's hard for you to get funding. Maybe we can come with you and work together to build a bit of momentum so that the CEO actually takes note and is interested. Well, I know in our hospital that she listens to families, right? Because that's her job. And it's a bit like a politician. They listen to voters, and we are the voters. And we need to be voting with our team and supporting them. But they may well say, actually, I would love to have a better hospital in the home service, but why don't we work together to figure out what's not working about it? So it could be the first step is doing a survey to find out what families are also struggling with this. Or it could be saying, could we put together a group of patients and families and different members of staff to talk about, it's not about funding, but it's about the way things work. It's about the way, whether physio is available, for instance, or whether how the HIF nurses integrate with the rest of the team. So it's about sort of trying to pinpoint what are the issues that are causing this to not work in our hospital and what can we do to improve it. I just want to go to see what the next ones were. I feel informed both about how well my hospital's CF team is performing relative to other centers in Australia in what areas they are trying to improve. Oh, I'm so glad that was a high one, because this matters. Hopefully it matters because what we've just talked about. This really matters. And do people here, anybody, hands up if you've seen the CF center comparison data on the CFA website? Okay, a couple people. So on the CFA website, you have to look a little bit, and I can't quite remember how you do it, but you should do that. You go to, Yeah, it is. But it is there. And so, and we're determined people because that's what we have to be in our lives. So you go to the CFA website, and it's worth having a look. Not that it tells us everything, but it tells us something. And I think you go to, anybody?
The search function on the CFA website is very effective. If you actually type in data registry or data,
Yeah.
You should get a list of options and that'll
Great.
take you.
And then what it'll do is it'll take you to the annual reports, I think, that they have every year. And most of those don't say anything about center comparisons. But one of them in 2010 did. And we hope that actually, I think that the data will come out again this year. Isn't that right? I think the next set of data is coming out. I actually think that's probably not good enough. I think it should come out every year because we have lots and lots and lots of data, which actually was from all of us. And so it would be good for us to see it in the most positive way. So we need to really reassure people that it's not about pointing fingers or saying, oh, well, if you're not as good, I'm leaving, I'm going here, but about saying, why is our center not doing so well on nutrition? Okay? And if it's not, so what could we do differently? Now, one of the discussions we had at my support group recently was about, what do you call those, food diaries. You know, that everybody hands up who's ever filled out a 3-day food diary. Fun. And now my kids do it, and one of them actually lives in the U.S. now. He's at university, but the one here, he writes sandwich. Next to there, he writes dinner. I'm like, Oliver, come on, help her out here. Anyway, so when I was talking about this with our group recently, I think Lisa was there, and we were discussing how much everybody hates doing these food diaries, and it was clear from what was coming up that there was a lot of like, well, and I said, what's going on? Turned out that everybody, I think bar one or two, lied on their diaries. And when I said, so why are we lying on them? We, me included sometimes. I said, so what is going on here? And people said, I know what I'm supposed to do. I'm just tired I feel so judged. I feel like a terrible mom because my child is skinny. I feel like I'm not doing a good enough job. And if I hear one more time that I should put some olive oil or some sugar on their food, I think I'll go out of my mind. So the thing is, the bad thing about that is that there's a disconnect between what's happening over here with the families and what's happening here with the lovely dietitians who are actually spending hours and hours of their life calculating weight and things, fat, for food that's not actually even going into the child. So instead, we maybe need to come together with those teams, particularly the hospitals aren't doing so well, and say, well, what could we do better for the kids who are on the bottom end of this graph? What do you guys need? You know, and I don't want to feel like a bad mom for this, but I do want my child to gain weight. So what kind of creative ideas can we do to make it happen? And that's where we come together with the team, and we say, I think we could provide some insight into what our lives really are like, and what really works for us, and why I can't get them to take Sustagen or whatever. You know, don't tell me that again. So that's not helping. But let's talk about what might help, right? And because we're part of that team, and they need us just like we need them, we can actually make some progress. But I think that there is evidence that the fastest way to drive improvement is transparency. Okay, that is not just in cystic fibrosis and is not just in medicine. It is in any industry. The fastest way to drive improvement is transparency. And the fastest way in healthcare is for patients and families to know how well or how poorly their area is doing, so that they can actually say, okay, that's not good enough. I love you guys. I think you're doing the best job you can, but I obviously need to, sort of like to go and speak to my MP or something. I need to do something because this really matters. Obviously, it really matters for you too. And we need to say that message gently and lovingly to people within the CFA and within our state organizations that we actually would love to see this data, not because we don't really believe our team is doing a great job, but we want to know what we can do better as a team. The last one is, I feel heard and respected by my healthcare team. Now this is a little bit more of an individual issue. It is absolutely essential, but it is a little bit more of we can't sort of make a policy to say, okay, doctors, you have to start listening. It needs to be more of a conversation where we say, I'm not sure that you heard what I said, or whatever. We need to work on that. We need to figure out our skills, and they need to work on their skills about how do we actually improve this. And it could be that coming up with solutions which say, maybe if I email you my questions the day before, maybe that'll work better. Or what can we do so that I don't feel like 15 minutes goes in an instant and I've got 2 months and no answers to my questions, right? So it's about thinking, what do I need to do now? I have to finish, or I'm going to get in trouble. I would love it if before today is over, you try to think about this. Just for each of us, we try to think about, what are the issues that matter most to me? What are the issues? Where did I put my heart and my stars? What are the things that I'd love to see happen? And then, what are 2 realistic things that I can do? And hopefully positive things that I can do to really to make that start to work. And who do I need on my team to do that with me? Do I need to meet some other families? Do I need just to have a chat with my CF nurse coordinator? What do I need to do to make this work? Because the reality is, the great thing, and there is one great thing about cystic fibrosis, and I'm not like one of those people who says, oh, I'm so glad we have it. But the only good thing about it that I've been able to think of is that we actually have an opportunity to improve where we head. As individuals, we can have an impact on our child's life by the things we do at home, by the way we interact with them, but also by the way we interact with our healthcare team. And that is a great opportunity. Don't take it as guilt. Guilt doesn't help us. Opportunity does. It's a great opportunity to think about, what can I do to really make a difference so that down the line I feel really satisfied that I've done everything. So thank you. I have written a book. If you're interested, I have them out there. It's a bit about patient-centered care and living with cystic fibrosis and how do we do what we do, but in the form of a memoir. And I'm happy for you to contact me if you want to talk more about things. If not me, please contact someone in your center to chat with them and get ideas flowing to make a difference. So thanks so much. If you have questions, please come up and chat.